It is an extreme honor to be with one of my rock star mentors, idols, Bruce Baird. Guy, you graduated from dental school in 1980. You've been crushing it. This is 2014. So what's that? 34 years you've been crushing it.
That's what it feels like.
And you're in a small town. What's your town?
I'm in Granbury, Texas, which is a big, large metropolis of about 7,000 people. So
Yeah.
out the Dallas-Fort Worth area.
And let me tell you why I love you so much is because so many businesses that evolved in the 117 largest towns in America that have half of the Americans really weren't consumer friendly. And if you look at the greatest companies, most of them were developed in the other half of America in 19,022 small towns, like Sam Walton and Walmart. He's the one who pioneered, yeah, we'll take it back because we sold you something that's crappy. But they didn't have to do that as Sears, Gibson's, TG&Y in Dallas because they could piss people off for their whole life. And I'm from Kansas, and you're just a good old boy down home Texan in a small town, and you're crushing it. And so I'm so excited to interview you. I just want to start off with this. I want to start off with you and I. I've seen many recessions. I remember, we saw the when I got out of high school. I was from Kansas, and we had 21% interest rates. We had 10% unemployment. It was 10% inflation, 10% unemployment, and 21% interest rates. Some of my friends whose dads and moms were in third or fourth generation farms lost the farm, and the dad went in the barn and blew his head off. But those recessions seem short. I mean, it seemed like a bouncing ball. They hit bad and then bounce out. And then I got out of school in 87, and we had that October Black Monday where the stock market lost a quarter. But it was short. It was like down and out. But this last one, this Lehman's Day, August 15th, 2008, my God, this is 2014. And from 8 to 14, it's just been flat, lousy, anemic. And what I want to throw you, the first question is, what do you say to these dentists? They've been out 10 years. Their economy is not moving. They're in a small town. Their production and collection hasn't moved since 2008. And you've been there, you've done that, you're crushing it. Take it away.
Well, I mean, Howard, there's a lot of things that you look at. First of all, you have to realize that patients spend their money with you based upon relationships. It's not really 2-for-1 happy hour at our office. I mean, we get one patient telling another patient about our office and come see us, and so it's building that individual personalized relationship. I know that in 2008, I started seeing things differently, because some of the bigger cases I was doing, they started, not being able to do it. And so, it became even more important. And one thing I like to tell docs is if I look at the week and if I look back at last week and I think to myself, do I remember all the new patients I saw? Do I remember their name? Do I remember who they were? Do I remember the stories about them? And if I don't remember those things, then I'm just going through the motions. I'm not really saying what I'm telling people to do. And so I have to reattach myself to my patients a lot. When things get going really good, the tendency is to kind of step back and go, hey, it's going good. I'm just going to, just wing it and go in there. But, I like working on my friends. And so every single patient to me is a potential friend and somebody who's going to be in our practice for the next 20 years. And I enjoy dentistry. Even after 34 years, I love going to the office. I love, working, and I love delivering the kind of things that we're able to deliver nowadays. So I think it really starts out building a great relationship with the patients. And when you do that, patients just, you have to go through that, build the relationship. They start to trust you, and pretty soon you're on a first name basis. You know everything about each other, and all I do is become kind of a consultant with them. I just tell them, this is what I would do if it was me. There's other options that we have, and we may have to do those if money or time comes into play here. But overall, let's really look at this as, this is what I would do. And patients respond wonderfully to that. And they always, even sometimes they can't do the work because maybe it's too much, cost-wise. They still refer other people. And it's very interesting, and so that's the one thing I could say is probably been the most important thing at any time, but especially now in this recession.
I've been in too many offices to count in the last, 25, 27 years, whatever. But I've noticed one thing that sticks out amazing. And you're known for not only amazing clinical skills, but doing the procedures productively, fast. I mean, you're just so organized. But what I've noticed with the greats is, you go into so many dental offices and an emergency patient will come in. And the assistant will go in there and take a pee in a bite wing, and the person hasn't even met the doctor. And so number one, that's not even legal because she just made a diagnosis to take radiographs, and that's not even legal. And then the doctor will walk in there and look at the radiographs on the view box or the digital computer, and then start leaning the patient back. And I'm just like, wow. And I did something fun for me. When I became an empty nester, there was this evening comedy school class. And I always thought I love comedy. I love cracking jokes during my lecture. I just wanted to go. And the biggest takeaway from that is a comedian, when they walk on stage, they got about 30 seconds to win over the audience. And if your first joke is making fun of them, you just lost half the audience. Or if you're a man and you make a joke about a woman, or if you're white and make a joke about Mexicans or whatever, you can't start. You gotta turn inward. But you only got like 30 seconds to win them over. And it's just amazing how guys like you, in my own backyard, there's some great ones like Omar Reed, and how they just walk in there and the dental's not even on the horizon, and they shake their hand and how are you doing, and they start the relationship. And you said first name basis. Do you introduce yourself as Dr. Baird? Or
You
what
know,
do you?
I say my name's Dr. Baird, and I said, but you can call me Bruce, and that's the way I introduce myself with everyone. So I don't do that maybe if it's a teenager or something like that. I'm just Dr. Baird. But if it's somebody a little older, then I just introduce myself as Bruce, sit down, and ask them how long they've lived in Granbury or
Exactly.
Weatherford or wherever town they came from. So.
In Phoenix, nobody was born here. I mean,
Right.
I think I've met 3 people that are born here. So you just got some standard questions like, so how long have you lived in Phoenix? And where were you born? And then you just start a relationship. And it's the most. You're known as the productive dentist. I think the most productive part of dentistry is that first 5 minutes of human to human dialogue, shaking their hand, talking. I always give them my card. Jenna, will you give me my card? I got one around here somewhere, but I'm the only dentist I know that gives my card with my cell phone number and my email. And last week it was so hilarious. I was sitting there talking, and my phone started to vibrate, and I just, and I'm talking to this new patient, and but I just want to check, make sure it wasn't an emergency for one of my 4 boys. And I looked at it, and it was a 480 number, so it should be back here. So I said, excuse me, and I took the call. It was her in the chair. She goes, I just want to know if that was really your cell phone. I cracked up laughing.
That is great.
Yeah.
Is great. Yeah,
So,
there's no question. That's awesome.
so what advice would you give dentists about how, because most dentists are part scientist and engineer and all that. So what tips would you give them on to be, I mean, you don't have to be an extrovert. You can play one at the office. What advice would you give them to be a stronger relationship building?
First of all, what I had to do is it's kind of an interesting thing. I'm in a situation where I was in Granbury, Texas, and we had a lot of new patients because we had a nuclear power plant right down the road. And so we had a lot of these engineers coming by. And I don't look at myself. I tell people that I lecture to, I said there's only 2 types of people in the world, engineers and non-engineers. And most dentists are engineers. We think like engineers. We put things together. So I had all these engineers coming in, and I'd tell them, hey, you need a crown, and, just trust me. And, what kind of metal is it? I go, yeah, it's good metal. It's just not something I look at. They need all that information. They need every detail before they can make a decision. The flip coin is you've got all these dentists that are engineers and their patients are non-engineers. And what they really need, and so learning, studying, reading every book you can get your hands on about how to communicate and how to connect with people. I had to do that. So I had to turn into a really good engineer dentist. Same thing goes for pilots. Same things goes for, people that check. And so my way of doing it was I had to kind of reverse roles. I use an analogy that I can introduce myself, and if I had 1 minute with 100 doctors, so it'd take a little while, I could pretty much tell you the top 20 producing dentists in the room. They're the ones who can shake your hand and talk and visit back and forth. Now, you may have somebody on your team that can do that and that can help you, but still you need to be able to open up those lines of communication.
You know how I can tell the top dentist, and I've lectured 1,500 times. You know how I can tell? 25 years I've been telling this. So the room, the average lecture is what, 200-300 people, and one side is just a few doctors and they brought all their staff, and the other side is just all individual dentists who came by themselves to save money. And the dentists who brought all their staff make twice as much money as the ones who didn't bring their staff. And the dentists who just sent their staff and didn't go, they make 4 times as much money. It's just a running joke. Like, where's your dentist? Oh, he's golfing. He never goes to these things. He just sends all of us. And their team is just crushing it. I know you're big with Vicky. Now, she's a hygienist.
She is.
Yeah. And I would rather have an overdeveloped hygienist assistant and receptionist than an overdeveloped. I mean, you could almost delegate out the personality if you totally have the long-term educated staff.
Yeah, you really can, and it's just the way you present it and the way you talk to patients about it. It really does make a huge difference when people when you can communicate well, and I think that above all, it's not. We always say it's education, education, education. I love Paul Homley and I are good friends, and Paul taught me a lot, and he's a mentor of mine, and he talked
and mine
about,
too.
Yeah, he said there's certain people that you want to educate, and there's other people you just want to tell them what they need to have done, and you need to know the difference. And so that's some of the things that I look at. But you can read. There's so much good information out there. There are so many good courses out there. Productivity is one of those things that people think it's working fast or doing things quickly. In dentistry, it really isn't, because in dentistry, we can do an enormous amount of dentistry, and it doesn't take that long. Now, there's the numbers nowadays, they get up there pretty good. If you have somebody and you're giving comprehensive treatment plans, I mean, it's not unusual to have a case that maybe $5,000 or $6,000 or $8,000 even, or even more if you're doing implants and the other types of stuff. So when it doesn't take that long to do that procedure. Most people are low producing in the country. Most of the dentists are doing, the average is $400 an hour. Well, $400 an hour, if you think about it, that's about 3 crowns a day. Well, I think you'd probably be out riding your bike by about 10 in the morning and still have run your business during that time frame. So those are the things that I look at. It's not really about how fast we do things. It's about how do I communicate to this patient of what they need, and they say, I want to do it all, and I want to do it now because I realize I do have this problem. And so, and we get that, and so that really makes a huge difference for us.
There was an idol mentor of mine out here, Omar Reed. Was one of the most controversial dentists ever when he came out with what he called the 90-second crown prep. And everybody said, oh my God, he's a horrible dentist. He only spends 90 seconds on crown prep. And that's not what he said. He said, when I stand there with the stopwatch, you're just drilling, stop, drilling, rinse, dry, drilling, and the assistant's leaving the room 3 times. You ask for a different burr. She's got to get up and leave the room. There was another guy, the most controversial piece we ever ran in Dentaltown was the 15-minute root canal. Do you remember that guy? He was a Texan.
Scott Perkins from
Scott Perkins, yeah, from Houston. Yep. And everybody's like, oh my God, if you do a root canal in 15 minutes, you're the worst dentist ever. So about 6 or 7 of us townies, Jerome Smith, a bunch of us, we went down and watched them. And what it was is that, you would load a file and then you go in and out, then you take the slow speed out and you change the file. He had 3 of them set up. He had 2 assistants. He did the same thing all the other townies did, but he was so organized. Every time he moved his hand, the trays were set up, the tubs were set up, the procedures were set up, and the guy was just amazing. It was like watching Mozart play the piano. It was just a master engineering piece.
Right.
And that's what you've been. Now you actually have dentists come to you and do over the shoulders on Productive Dentist Academy.
We do. We have dentists that come in and just spend a couple of days, and what they realize is, I don't run around like a chicken with my head cut off in the office. I used to. There was my first 15 years in private practice. Yeah, I was running late. In fact, the way I introduced myself to people was, "Hey, I'm so sorry, I'm running behind." That was the way I introduced myself. And so today that doesn't happen. I mean, I'm on time for lunch, and I get home. Usually, I'm home by 5 at 5:15, and So it's really that what they get to see is how focused we are on our procedures. It's not about literally how fast we're doing it. In some procedures, we actually recommend at Productive Dentist, we recommend scheduling based on productivity, not scheduling based on time, which is really counterintuitive for most people. What that means is if they have a goal of 500 an hour and you're running 2 chairs and your goal is to reach your goal, whatever that is, then if you had 2 crowns to do, and let's just say they were $2,000 with the build-ups, or whatever the price, and your goal is 500 an hour, we actually schedule that chair for 4 hours. Now, people say, that's crazy, Bruce. Why would you do that? I said, well, because I can, and because I reached my goal for that 4 hours. I'm on goal for the day. What you find is you've got plenty of time to go check your hygiene. My hygienists don't wait for me. When I go over and do some other procedures, when I go see an emergency patient, I end up producing about 30% more each day than what I have on the schedule because I have time to do it. The worst thing is when you get behind, then what you do is you go in and you start taking away work. And you have 2 crowns on one side and 1 on the other, restorations, and you say, well, why don't we do these next time? Because you know you're behind and you're going to be further behind if you do all 3. And so we end up with this counterproductive way of scheduling. Whereas if a guy wants to do 700 an hour, well, you book $700 an hour procedures and you run 700 an hour, and that's the way you do it. So it's not really how fast we do it. It literally, I can take as much time as I want as long as I'm within my production goals, which I run production goals in the mid 2000s, so 2,500 an hour. So, you can do, I have to be more efficient in order to get those numbers, but at 500 an hour, the average dentist at 400, you don't have to work very fast. You don't need to go learn how to do things faster. You need to learn how to get people to say yes to the dentistry, because you're sitting around doing 3 crowns all day or doing 10 fillings, and the rest of the time is just piddling.
So let's talk logistics. Are you a solo practitioner or do you have a partner?
I'm not. There are 3 of us in our office.
There's 3? So is that 2,500 for 3 dentists or just Bruce?
That's just me. That's me.
So 25. So you want 2,500 an hour, and you work an 8-hour day Monday through Thursday?
I've worked Monday and Tuesdays for the last 10 years, and so I just work 2 days a week, which allows me to be very focused. Love going in, but I mean, my average production is probably 140 to 150 a month, something in that neighborhood.
Just your production,
just
not the
not hygienists, not the other docs.
So Bruce does 140 a month, and that's 2,500 an hour times an 8-hour day. So that's 10,000 a day.
About 20 grand a day.
Oh, 20 grand a day. How did I get that right? Oh, 2,500. Yeah, 5,000, 10,000. Okay, so you do 20 grand on Monday, 20 grand on Tuesday, and basically 8 days a month and knock out 140.
Yeah, and I'll usually work 7 days because I'm going somewhere one of the 8 days. So, but in 7 days, I've kind of committed to my team that I'm going to produce this much dentistry. And so that's what we do.
How many operatories do you use to do 2,500 an hour?
I use 3 ops.
You use 3 operatories, okay.
I have 1 that's what I call a non-productive operatory, and I have 2 that I call productive operatories. Although they're all productive, the 2 are the main ones that I'm using for scheduling larger procedures.
And I want to make a point real quick that when we look at the cost of a dental office, just look at the ADA numbers. That says the average dental office has 2/3 overhead, 65% overhead. So 1/3 of that collection is doctor's labor. The next highest item is staff labor, and that's going to be 20% rural, 25% urban. So you're looking at 55% labor. And then next would be lab, 10%, supplies, 6%. Equipment's only 4%, but almost 100% of offices I've been into, probably 99%, you always see this 55% cost doctor and staff standing around waiting for a chair.
That's right.
And it's like, do you even know your cost? What percent of dental offices need an extra operatory today that would be what you call the non-productive, the overflow, whatever?
99%.
99%. I just talked to a dentist the other day whining because he lost massive production because a chair went down for 2 days. And he was all mad at his supply rep because it took 2 days to get it back up. And I'm like, you're mad at the supply rep? You don't have an extra operatory? And I also want to tell you that every hospital has an emergency room, because emergency rooms are huge money. And dentists have this cult in their mind that Mrs. Wimpleton, who comes in every 3 months to get her cleaning and brushes and flossing, is a grade A patient. And that pig that walks in, hadn't been to the dentist in 10 years with its toothache, is disgusting varmint, and you're ruining my schedule, and you didn't have an appointment, and you're a walk-in. Why don't you just call him a leper and a sinner and throw a Bible at him? I mean, and those are fun, emergency room, blood and guts dentistry, and big money. What percent of your 140 a month is just an emergency?
Same day dentistry probably that comes in, I'm probably 20% of what we do.
And that's and you've already paid your bills, so that drops right to the bottom line.
It drops right to the bottom line. And we, what I love is the fact that because of the way we schedule, I have time to see them. My team will come back, in our morning meeting, they'll say, when would you like to have emergency patients? And I can pick, these are the times where I'd like them when they call. So I don't ever let anybody not come in. I mean, if they're having a problem, I have time to see them. I don't care what's going on.
And doesn't it just feel much more fun? I mean, your choice is to go in and do an MOD, posterior composite, or go in a room with someone who didn't sleep last night and is in severe pain. Which one gets your adrenaline going?
Yeah, no, there's no question.
I'd rather work the emergency room than be a dermatologist popping a pimple all day long. I mean, I love the pain.
Oh yeah, well, that's one of the things that you made a good point about is having extra chairs. I think, especially nowadays when we have the CAD/CAM technology, the CEREC technology, E4D, where you can do it all. You don't want to just let somebody sit in a chair that's a productive chair when something's milling. That's taking 20 or 30, 40 minutes. But having that extra chair allows you to do things at a much higher productivity per hour. And so I love having that extra chair. And if I need one, I've got an extra chair. I use the 3, but I've got a surgery suite and I can use that. And I've got, usually one of the hygienists, we have 5 hygienists. I can use one of their rooms if they're not there that day. So I'm liable to use, I'd get a lawn chair and put it out there if I had to. So that, whatever it takes.
So talk about, you've been taking dentists off the street, running them through your productive dentist academy. It's 2.5 days. Right. So tell them everything they need to know that you teach in that academy on this podcast in the next 40 minutes, so they don't even have to go.
Well, I'll just slam it all in there.
Just slamming it in 40 minutes.
Yeah, it really does start with the relationship, and that's what we talk about. Dead seriously, it's the first thing we talk about, because until you get that part down, it really makes it difficult. And the next thing we talk about is risk factors. And John Coyce was the first one I heard start talking about risk factors back in the mid-'90s. And the neat thing about that was it took the pressure off me, because what I realized is, and I knew it, but I never really held people accountable, meaning, they're a grinder, or they have high decay risk, or they have high perio risk, but you wouldn't hold these people accountable. What I mean by that is they don't show up for their 3-month recall, and they need to be on 3-month. They've got perio, and all of a sudden you look down the road and you say, they missed their appointment. Your hygienist says, well, things are looking pretty good. I mean, I think your teeth are looking pretty good. Well, once you tell somebody their teeth are looking pretty good and they're a high perio risk, that means I'm immediately, if I'm a patient, I'm on 5-month recall, 6-month, 8-month, or whatever. So what I tell people is we treat people with a periolaser laser. We use it a lot. And I go in and treat
now, is that the LANAP procedure?
It is, the LANAP procedure. I've been doing that for 11 years.
Okay, explain that to all of our viewers around the world who have no idea what LANAP means.
LANAP is a laser-assisted new attachment procedure, which it's doing osseous surgery without laying flaps, without doing apically repositioned flaps, and it's a phenomenal procedure. And I've gotten a chance to do several thousand quadrants of surgery with this, and it works very, very well. But you have patients, there is no cure for periodontal disease, and you'd use this laser, and patients think it's a cure. Well, what I would tell them is, it's kind of like you have leukemia. You're in remission right now. So there's an opportunity for you to be in remission for, as long as you're following the rules and we can keep track of you, then we have an excellent chance of you keeping your teeth the rest of your life. Same thing with decay risk, all the dry mouth syndromes and everything we've got now. And I tell them, I said, look, we use Carry-Free that Kim Cooch, our buddy up in Oregon, developed. And I mean, we use it religiously with our patients that have high risk for decay.
So you mean when you say use religiously, that means Christmas and Easter?
Christmas, Easter, and all those other holidays too. So we're constantly telling our patients they have a lot of restorations. If they have any active decay, they're using Carry Free. And what do we tell them is, how long are you going to be using this? It's going to cost you $1 a day. It's cheaper than anything I can do for you as far as dentistry is concerned, and you're going to have the opportunity to be able to prevent a lot of these problems. You also have to quit drinking the Dr. Pepper and the Mountain Dew, and I visit with them about this before I ever even look at the teeth. I'm talking about these risk factors.
And the CDC just released something yesterday, I was reading last night, that smoking plays a bigger role in it than they ever thought before, and they're putting almost more weight on smoking than they are on the pathogens now. And they're all trying to look at the mechanisms of how the carbon monoxide, I don't even think they think it's the nicotine.
Right.
Yeah.
Yeah, deplete, the oxygen uptake in the cells, and there's so many different things to look at. But when my hygienist sees that patient, we have keep track of it every morning. Are they using their Carry Free? If they're using it, then they need more of that appointment.
So tell them about Kim Cooch. Why tell them about Kim Cooch Carry Free in a nutshell.
Kim is I call him a dentist, but he's an inventor, and he thinks outside of the box. And what he did was come up with basically a base rinse. And this base rinse neutralizes acid in the mouth. And it's the first time anybody's come out with anything like that. And for me, it's the first time in 34 years, and I've been using his product since he came out with it, that I feel like we have something that can literally stop decay. If you have a basic environment in the mouth or a more neutral environment, you can't get active decay. And so I explain this to patients. So my education is educating them about what they have to do, not what I'm going to do for them. And that's a big difference. And so we hold them accountable every time they come in. And with Kim's products, he has the toothpaste, he has, all of the stuff. So it's something that we use ongoing. Another fine example is when we look at their functional risk. We give them an occlusal guard. You ask them at the hygiene visit, so how's the occlusal guard working? And they go, pretty good, or you say, hey, are you wearing it? Well, yeah, sometime, which that means they're never wearing it. They don't even know where it is. Their dog ate it 2 months ago. So we look at them, we say, you've got to wear this every night. This is not something that, we know that we've done this work. You broke down what God gave you, and you did it in a short period of time, and now we're expecting our work to last. And it won't last unless you do this. And unless you wear the occlusal guard, unless you use the Carry Free, unless you come in for your regular recare. And it took the pressure off me because, I realized it's not my problem anymore. It's not my problem. I used to replace crowns. I did more free dentistry. And the reason I was doing free dentistry is I wasn't holding them accountable for things I told them. I told them, you got to do this, you got to do this. And they weren't even doing it. And then I felt bad because the work didn't work when what God put in there didn't work either. And so I don't do that anymore. If they stay accountable and they do the things that we ask them, by golly, first of all, they love us and they're going to keep coming back, and they wonder why no one else has ever told them these things. But the other thing is, if they have something break, it's full fee. And I sit down and I enjoy working on them. It's not my fault. It's yours, and you take responsibility for it. But we've talked about it. It's not a threat. It's just, hey, I know those things are hard to wear. I wear one. Oh yeah, I know about that. Oh gosh, I use the Carry Free. So,
Bruce, I want to take a little detour on that. There's a big problem in dentists. They used to always say dentists had the highest suicide rate, but there's not a lot of data to really say that. But now our soldiers have an astronomically highest suicide rate. Nobody comes close to the poor boys that had to go to Afghanistan and Iraq, and they just kept sending back and back. So now dentistry is not even in that league. But I always see so many dentists so stressed, and they're so stressed. And I think a lot of it's because that engineer mind, they're trying to do a perfect crown on a person who showed up with a Mountain Dew, hasn't flossed, gets their teeth cleaned every 3 or 4 years, and they're throwing instruments and nearly having a heart attack and hating their job because that margin wasn't just perfect on a person who's going to leave and go get a Slurpee And dentistry is so frustrating because the whole thing starts with a newborn baby that doesn't even have Streptococcus mutans or P. gingivalis, and then mom and dad and grandma and everybody starts kissing it on the mouth and totally infecting it. And then, so it's just so. Sometimes it's just overwhelming when you look at dentistry at 30,000 feet. It's like, if we didn't kiss our babies, there wouldn't even be dentistry. They wouldn't even have P. gingivalis, Streptococcus mutans. Now we have the crazy thing, when you and I got out of school, oral cancer was linearly related to packs of cigarettes per decade smoked. And now we see an explosion of young girls who aren't smokers or drinkers getting it because they're getting HPV. Again, dentistry is an infectious disease.
Right.
Everybody knows after AIDS that below the belt STDs, the whole planet understands that. But the whole planet hasn't even began a conversation about talking above the belt that, you can go to a bar and kiss someone and get HPV and oral cancer. How many times have you seen it where the girl comes in every 6 months, her whole life, she's fine, then she goes to college and comes back with gingivitis and 4 cavities, and you're like, Karen, you're kissing a boy at ASU who has cavities and gum disease, and they're like, so it's very, very frustrating. So summarize your risk factors. You talked about relationship, then you went into risk factors. Lay out the risk factors.
I mean, really, you go in, and first thing we look at, we lean the patient back. I'm always looking first at their periodontal risk. We then go in and look at decay risk or cavity risk. Are they on medications? What are their habits? What do they drink?
Who they're kissing.
Yeah. I haven't gotten into that part of it yet.
Well, you have to. I mean, if the dad doesn't go to the dentist, I mean, I'm in Phoenix. A lot of people ask me, "Are you in Scottsdale or Paradise Valley or Sunset?" No, I'm in Phoenix. I'm across the street from the Guadalupe Indian Reservation. And if your husband hasn't gone to the dentist in 10 years and has 4 teeth rotted off to the gum line, and you're in there brushing and flossing, but you're kissing him every morning and kissing him every night, that's the highest risk factor there is.
You better believe it. You better believe it. And so we just kind of go through those where they have the, periodontal risk, their decay risk, their functional risk. Does this person have giant masters or they've already broke their teeth? So this guides me in my decision making on what type of treatment they need. And finally, I look at aesthetic risk. Does this person smile and show their nasal septum? And, are they just crazy, as far as how much gums they show? Well, that requires a little bit different attention to detail than somebody who smiles like you, with that, I can't see your gums. And so or me.
You can't even see my teeth, can you? I mean, when I talk or smile, you don't even see my teeth, do you?
Not much.
That's one of the advantages of obesity.
Yeah, and as we get older, things head south, so we're okay. But yeah, so those are the risk factors I look at. I go through these risk factors with the patient. They get on board with what we want to do. And usually at the time, I haven't even looked at the teeth yet, honestly. I mean, I've looked at their x-rays with them. I've looked at their risk factors, and I always tell them the same thing. I said, Bob, we're going to lean you back. I always look at the same 4 things on everybody, and I just go through it. I said, your gums, even though you haven't been in 2 years, to be honest with you, your gums and your oral hygiene and your bone levels look really good. So
okay, that's number 1. That's 1 of 4.
You bet. It's 1 of 4. And I said, does that mean, well, I actually have 2 more, physiologic and psycho risk.
Okay, go number then. So it's 6. So go through it numerically. And this will all be in the notes. We transcribe all of our podcasts.
Good.
So the viewer doesn't have to stop and write this down. So number one.
Number 1 is periodontal risk. Always look at the foundation first. And what we're doing is we're just trying to find out where are they at? Are they, do they have periodontal disease? Do they have, deep pockets? All of those things we're looking at. Or are they pretty good shape? The next thing I look at is decay risk. If they've got active decay or tons of dentistry done, what I want to do is start looking at what are you drinking? Because, what are you drinking? What meds are you on? And those are things that I look at because they don't know it. Even though they're sitting there with a Dr. Pepper, they probably know it down somewhere deep, but it's never really been a conscious thought process. And so I just go, so you're drinking those every day. Well, do you realize that that's what's causing all your problems? They go, no, maybe. So they didn't even realize it. Now you just say, well, if you keep drinking that, then you're going to keep spending money. And whether it's dentures or whatever, you're headed, we've come to a Y in the road. You go this way, you can change habits. You go this way, this is what you're going to end up with. And I'm not condescending to them. I'm just telling them the truth. And they really appreciate it. And they go, So that's the second thing is we look at decay risk.
Can I interrupt on that one
Yeah.
thing? My boys have always warned me for the last 20 years that I'm going to get the crap beat out of me someday because I'm out here in Phoenix and it's 115 outside, and we'll be driving around the corner and you'll be seeing the construction workers. Most of them are Hispanic. Most of them were born in Mexico or Hispanic, and they'll be taking their break under a tree and they all have their 2 liter bottles of Dew. And I'll just
Yep.
stop and I'll walk out there and I'll just tell them, if you guys drink this 2 liter bottle of Dew, you'll have no teeth when you're 30. It doesn't matter if you don't have dental insurance. Here's my card. You don't even need dental insurance because your problem is you need to drink water. You can't be drinking this stuff. And my boys are like, Dad, someday they're just going to get up and beat the crap out of you, and they love it. They love it because someone actually cares.
Cared about them.
And they take my card. I mean, I've had a huge Guadalupe Indian Hispanic practice just stopping and giving the workers and just pointing to their Mountain Dew because it is all diet. Much of it's diet.
It is. It's diet, and what I'm seeing nowadays is the medications are on because those meds.
Now, is that mostly elderly you're talking about?
Yeah,
Would you say the young is the soda and the older is the medication?
It is, but the combination is the killer. Either one by itself, but a lot of these, I'd say 50 and older, where they're getting on blood pressure meds, cholesterol meds. That's the way to solve every problem is give them a pill. And so they're getting these medications which dry the mouth out. So now you've got saliva, which is a natural cavity protector, being gone, and they're still putting sugar. Because I tell them, I said, you're eating the same things you've been eating for the last 40 years, but now you're noticing the decay start. That's when you start seeing that reduction in saliva. Bingo, they go back into high risk. Third thing I look at is bite risk, functional risk. How strong is their bite? And that basically means, do they have TMJ issues, musculoskeletal problems around the head and neck? Are we going to make them an occlusal guard, some type of an appliance?
Can I interject one thing in there? On the big debate on Dental Town, how much of temporomandibular disorder, disease, joint problems do you think come from stress in the brain versus mechanical engineering forces? How do you think? How do you wrap your thoughts around that?
I'm thinking it's a much more, skeletal muscle related, but the stress, the average stress in America, for the average person, it really does put an enormous amount, because there are times what I tell people, you go through this cyclical nature of grinding and clenching. And it also can be very related to one of the other risk factors, which is physiologic risk, which is sleep apnea and snoring and clenching and grinding. So
what's taken me from putting downward pressures on stress and more upward on biomechanical natures is getting my CBCT and having a board certified Dale Miles oral and maxillofacial surgeon showing me these routine scans and pieces of cartilage in the joint space, and
sure.
and you're just looking at this like, wow.
Sure. Yeah, there's definitely, it's multifactorial, no question about that. But we have so many other things. Like, for instance, some people don't really grind and clench that much until they go on vacation with their 5 kids. Then they grind and clench the whole time they're gone. So stress in different ways affects people differently. But yes, skeletal muscular and just how the brain works, it is, and you've got to give your dentistry some protection, because if they tore up, again, I always use that deal, if they tore up what God gave them, then what makes us think that if we do perfect margins that it's going to work? And it's not. And I learned that lesson from doing full mouth rehabs on patients after the fact. I said, oh yeah, let's do a full mouth after they'd already had another full mouth rehab done before, and saying, well, my work's going to be much better. Look at these, look at these crowns. And mine failed 4 years later too, because the patient, dipped and chewed tobacco with sugar in it, and they just destroyed everything. So,
and like I said, the original God manufactured tooth failed. Like yours is going to be better than that.
Yeah, it's not going to happen. And so the next thing I look at is I look at the aesthetic risk. Do they have a big, giant, high smile? Is it going to require a special ceramist? I send stuff to certain ceramists when I want a certain type result. Obviously, all of it, we want it to be great work, but there's certain stuff you need the extra little touch. It's going to cost a lot more, but I just charge the patient a little additional, and I tell them.
Let's say it was your wife or daughter, and it's high aesthetic needs anterior. Are you doing porcelain to metal? Are you doing all porcelain? You doing Empress? What are you doing?
I'm doing actually nowadays I'm doing Emax Emacs in the anterior, doing it myself with CAD/CAM using Cerac. I've gotten very good at staining, and if we need to do something different, we call Eddie Corrales from down in San Diego. We have Eddie come in. He's a ceramist, and he can help us in office to do full mouth smiles. So we do same day smiles where we'll do, oh gosh, I just had mine done. Eddie did mine 6 or 8 weeks ago. We had it all done in one day. It was a long day, but we got it all done, start to finish.
Now he's a lab man out of is he Florida or
San Diego?
San Diego. Yeah. Okay, yeah, he's amazing.
Yeah,
he's amazing. So I asked him to do my anteriors, and he said I was so damn ugly I should go to a vet and be put down. So he wouldn't do it.
I can work on your behalf. So yeah, it's all good.
But I didn't go to. I went to the vet to be put down, but he didn't take my insurance. So, that's why I'm here today.
Yeah, I understand. So, but we've got the fifth risk factor, which is physiologic risk. And that's where I look at a patient and say they've got a 17.5-inch neck. They've got erosion on their teeth. They've got, and what that is, I look at sleep apnea. And I've got sleep apnea pretty severe, and I realize how it affects me medically. And so, if you got a 17.5-inch neck and you're a male and you snore, you have a 95% chance of having sleep apnea.
So look at my neck on the podcast. What do you think?
If you're a snorer, you've got a 95.
Do you think I have a 17.5-inch neck?
I think you do.
Yeah, and I scheduled my sleep deal is coming up in a couple weeks.
Good, because you need
to. I'll be 52 this month, so I thought I got a fat neck, and because of that,
let me tell you, it's a huge difference. And
are you sleep apnea? Are you on CPAP?
Severe sleep apnea, and didn't know it until I had a dentist come in and train our team. And I took home a home recorder and found out not only did I have it, I was very severe. So I tried 8 different oral appliances. I had surgery, a genioglosal advancement. I had a bunch of stuff done. Bottom line is none of that helped me. It does help. Sometimes helps others. Certainly oral appliance therapy can help the mild to moderate case, but mine was so severe. I wear a CPAP every night. If I forget it, I'm in trouble because I just.
So how long have you been on CPAP?
Probably 5 or 6 years, but I've known I've had sleep apnea for.
And what? So take every one of us back. So tell us, like, before CPAP, after CPAP, how long did it take? Did you feel a difference? Did you feel more refreshed in the morning? Did you have higher energy? Tell us what happened to you personally.
All those things you said. I mean, I was tired. I would fall asleep at Sonic drive-ins ordering, and I mean, it takes them like 1 minute to bring your drink out. I was drinking probably 6 to 8 liters of Diet Coke, which is so good for you, which I haven't had caffeine in 2.5 years now. I wake up refreshed. My body's producing human growth hormone at night. I feel like working out now. I feel like getting on the treadmill. I feel like getting on the elliptical. So I'm in the best shape now that I've been in my whole life because I didn't realize how it was affecting me. It just made me tired all the time. And I'm pretty high energy. During the day, I'm fine. As soon as I sit down, you give me a little golf on TV or anything, which that still makes me go to sleep. But I love golf, but I can sit and go to sleep. Nowadays, my brain is thinking better. I function better. It's just it's amazing how that works. And so the last risk factor I look at is the psycho risk,
that's number 5. No,
that's number 6. Physiologic risk.
What was 5?
5 was physiologic risk. 4 is aesthetic risk. So it goes physiologic, then it goes psychological risk, meaning I want to try the best I can to figure out if this patient's nuts before I work on them. And some people just are on that deal where it's like, I think Dick Barnes used to call that the heart muscle and stomach lining fee, where he would just, immediately when they start griping, bitching about their previous dentist and their previous spouse and their kids, and every negative word turns into $250 additional fee on my treatment plan. The problem with that is, and the largest I've ever done was $13,750. And we call that, what Dick used to call it, was a reconstruction fee. And I tell them straight up, because your case, Howard, is so tough, you're going to see a fee that's called a reconstruction fee. And insurance doesn't cover that. But that's because of how difficult your case is. And the patients, I'm trying basically to get them to go somewhere else, but it's amazing. A lot of them go, okay, well, I'm ready to do it. Let's do it. So at least if I'm going to be working on somebody, I'm going to be getting reimbursed at the highest level, and I'm much more patient. But there's some folks you just don't need to work on. Just say no. Just say.
So you and I were both Barnesified. That's what we used to call it. That back in the 80s. We go to a seminar and get Barnesified.
That's right. Get your 5 slides, show the before and after, and you can do 100% case acceptance.
And again, another classic example of just Mr. Personality. He's tall, dark, and handsome. He runs 5 miles every morning and puts his rice in a steam cooker, but he's just got that $1 million personality. He just walks in there and he makes everybody feel warm and fuzzy, and then water or whatever he tells them they need, they just buy it. Same with Omar Reed. The greatest do that relationship. They just nail the relationship.
And that is super, super important. And the thing that got frustrating in 2008 after the recession is the same things I was doing. In other words, I was doing the relationship stuff, and then I would step into the, going through the risk factors, and everything was going great, and then I would tell them the cost. And that's when we started seeing a real difference. A lot of the big cosmetic guys in the country saw big drops in cosmetic cases. The plastic surgeons, saw 50% of their, surgeries drop. So there's been a lot of change in what people feel like they want to do for themselves that maybe insurance doesn't cover, whether it be implants, cosmetic dentistry, and those types of things. So we saw a lot of those cases go away.
So you're in a small town of 7,000. I'm out here in the Phoenix metro, 4.5 million. Since that 2008 recession, in 2009, 88 dental offices did a bankruptcy, and there were 2 groups, and half of them were the cosmetic dentists who their whole life have been doing these big cosmetic cases where people just come in, take out everything, all the metal, all the gold, and redo it all in Empress Beauty. And they lost all other skills. They couldn't do root canals, extractions, fillings, wisdom teeth, whatever, crazy. And then the other half was, I'm just going to go into a strip center and build a 5-operatory op and do a bunch of direct mail advertising, and it'll all work. And basically, in 2008, 9, 10, 11, 12, marketing just didn't work. I mean, I don't care what the marketing gurus told you. I mean, I'd been marketing for 25 years, and the return on marketing just fell to the floor. It just didn't work.
Right.
So you're known for financing. I've only got you for another 13 minutes. Let's talk. Tell them your financing insights.
Well, the thing that happened was we think that if a conventional third party financing, say a Care Credit or a Springstone, doesn't approve somebody for financing, then why should I approve them? Because the old deal of in-house financing, why, I've been telling doctors, don't do that. Don't do that. Let the bank be the bank. You be a dentist. I was wrong. I was so wrong. 180 degrees, a different way of thinking now. And it makes a big difference when you get on the correct side of interest. Because all of a sudden I began looking at these cases that Care Credit wasn't approving. And so you have this third-party financing, but what about the 60%? The 60% of these folks, or 50% that they say no to, then what are our options? So I'd be talking to them, I say, what are your options if they say no? And everybody had the same look. It's this blank stare, like, well, they prepay, they do a third, they do. And Gordon Christensen, just about 4 months ago, said that 9 out of 10 crowns now that are done in the U.S. are done 1 crown at a time. And that's where we've gone. It's gone from 7 to 9 since 2008. I don't want to do 1 crown at a time. I'd rather do 4 because the patient needs 4. I'm not going to, they need 4 crowns, but how do I allow them to be able to do it? They didn't get approved by Care Credit. They didn't get approved by these people. Well, what I figured out and what we found out, the reasons we've never done it ourselves is because we've been told not to. Number 2, we don't know how. We don't know how to charge interest legally. There are dentists out there that have their own plans, and they're so they are not following the rules and regulations that have to be followed because it's gotten to be a big deal. And number 3 is the biggest one is, what if they don't pay me? And if they don't pay me, then I did all this work. Well, here's the way to look at that. First of all, if Granbury Dental Center, my office, decided to do our own financing, every time we called somebody when they were late for a payment, they would see on their phone, Granbury Dental Center. They know they're late. They're not going to answer. The average collection rate right now in the U.S. in dental offices is like 93%, 92.7. So you're leaving 8% on the table with your own collection on people that you're not even doing financing on. So my thought process, and I was talking to my partner, Jeff, and he said, well, you think we could finance ortho? Well, ortho's been being financed by dentists for years because you can take their braces off if they don't pay. Well, bottom line is, I said, well, how much do we have in it? He said, well, if we could get $2,000 down, could we finance them? And I said, how much do we have in it? He said, $400, $450. And I said, and what are we charging? He goes, $5,500. I went, so we're doing $450 and we charge $5,500. And why aren't we not financing that? I mean, it seems like a very small amount that we're putting into something. Why aren't we doing it? With those reasons I said a minute ago. But what about like a CERAC block? What about it's a $30 block. We've got a crown that we're doing for whether it's $800, $900,000, or whatever it is, and it's going to cost me a certain amount of time to do it, and the average dentist is producing $400 an hour. Well, what if instead of doing one, I was able to do 4 or 5 at a time? Well, now I'm producing $3,500, $4,000. Am I at risk of not getting paid? Yeah, I'm at risk until you realize what interest does. And when I have 5 people that are doing 4 crowns at an average interest rate of somewhere between 9.9 and 17.9. 9.9 is actually for what I call the A patients. 17.9 is the E patients. You would think you don't want any E patients, but to be honest with you, 13% of the E patients default. And guess what? That means you have 87 paying you full fee at a higher production per hour, and you're receiving 17.9% interest. So you can literally have, of E patients, you could have 1 out of 4 not even make a single payment. We also recommend that you take 20 to 30% down. And that's, you get 20 to 30% down. It covers your hard costs. So my actual the lab costs, the supply costs, those things, I'm getting covered with the down payment. But now I'm able to help people have more dentistry. Because when you tell somebody they need $7,000 worth of work, people say, oh, well, they don't need to do that much dentistry. No, because you're just doing 1 crown at a time. If I told you needed 5 crowns, or if I need 5 crowns, I want it all done today. Or if I believe I need them and I'm able to get patients to accept my treatment, I don't want to have 10 appointments for 5 teeth. I want to have 1 appointment or 2. And that's the way every single patient is. I get people to raise their hand in the audience. I never have anybody say, I want to do it in 10 visits. But the reason we do it 1 at a time is because we think that insurance is the only way they're going to be able to do it, which is not true. As a matter of fact, I have people all the time now. I said, if your insurance is $1,500, let that be your down payment, no money down. Let's get all your work done. But we think, oh, let's wait every year and do 1 at a time. As well as I do from a business standpoint, that is not the most profitable way of doing things. And so that's what we did. We started a company called Comprehensive Finance. And that company really is the third party. Dentists know us as Comprehensive Finance, but patients know us as Compassionate Finance. So it's a different name. So when they get phone calls, they're not getting it from your office. They get the phone calls from Compassionate Finance. It's all done with ACH checking. So patients, a little deal, they said, man, this is great. I can't tell you how many times that patients just can't believe they're going to get their work done finally. Because the commoditization of dentistry is happening. We all see it. And the reason it's happening is because patients are given no other opportunity to do anything else. So they have to go down to the, I call it the cheapo depot. They have to go down there and have $300 crowns. In LA, there's a billboard out there that says free implants. So is it going to get any lower, than free? There's a scam there somehow. So you're not going to be able to compete on price. You're just not going to be able to. I love the fact that I do everything. I do implants, I do cosmetics, I do crowns, I do fillings, I like doing dentistry, and I don't want to be just known as one person or another, but it allows me to be able to do all of that patient's dentistry.
So how does a dental office evaluate and see if they want to do comprehensive finance?
Really, they could go to comprehensivefinance.com, and you talk to Charles Brown on there, and Charles can walk you through exactly what it is, how it works, and we have, well, right now we have over $35 million now that's out with dentists that have done their own financing, over 18,000 patients with a total default rate of a little over 5%.
Say those numbers again.
We have 35 million in self-financed or office-financed dentistry, over 18,000 patients, and a default rate of 5.1%.
But how many dentists is that? How many?
That is about 1,000 dentists.
So you have 1,000 dentists doing that right now. And to
Right
our
now.
international viewers, is that only in America? Do you have any Canadians, other countries?
Right now, it is just in America, but we do have some inroads in Ireland, New Zealand, Canada. We really are wanting to get the word out because we're not in competition really with third-party financing. These are people that aren't getting finance, but we want to.
Is there a thread on Dental Town talking about this comprehensive finance?
There's several different threads. People talk about it and ask questions about it. So they could go on Dental Town and put down comprehensive finance. You'll get to see the threads and all of the comments that have been put on there. It's not as long as the productive dentist thread. We've only been around for 3.5 years, whereas productive dentists have been around 10 years. So,
well, I wish Charles would talk to my office manager, Sandy.
Well, let me tell you, I would love to. I'm going to be out your way anyway. We'll get together and I'll talk to her.
When are you going to be out?
Probably in the next 2 weeks.
Really?
So, yeah.
What you got going on?
Well, I'm going to be out in L.A. and then I'm going to be out. I've got a buddy of mine that lives up in Scottsdale, so I'm going to go by and see him. But I'm going to be in your area. I think it's 2 weeks.
So you're going to L.A. What's going on in Lower Arkansas?
Well, Lower Arkansas, I'm actually going out to take the pinhole course that Dr. out there. I'm just interested in, I do some connective tissue grafting and stuff, and it's just, it's tedious work, and his technique seems like it's a really neat new way of looking at things. So, and I can pass that on to my productive dentist members that have gone through.
And I want to say this: watching dentists or just watching humans, I still think if I had to pick one ingredient to predict if a kid coming out of high school will be successful or not, it's always the kid who's naturally curious. Mm-hmm. It's not their GPA, it's not their SAT scores. And guys like you and me, I mean, I'm 52 years old. Here you are, 34 years doing dentistry, and you're flying out to LA because you're curious about a new way of looking the pinhole technique. Yeah. And it's just that natural curiosity.
Well, I'm curious. If there's an easier way of doing it, I want to figure it out. So, and it sure looks promising, and I've got a couple other things going on out there, but it's just, I'm looking forward to that course.
Okay, so I've only got you for 2.5 minutes, so I want you to do a close, and I want the close to be, tell them why they should do your 2.5 day Productive Dentistry Academy, and should they bring their own team? Should they come alone? Is it 100 people in a lecture room? Is it small? Do the big close for the Productive Dentistry Academy.
We've been doing the course for 10 years, and it started out with 8 dentist friends of mine who said, Bruce, you're productive. Why don't you teach a course on it? And I said, all right, let's do it. And so we did a course in Dallas. We've been doing them ever since. Now we'll end up with, 30, 35 offices in the room, 35 dentists, sometimes 35 to 40, and we'll end up with maybe 120 staff. So if I had to tell people, what are you going to learn there? Although we have consultants, we have a marketing company, we have all those things, what we do is we teach productivity. We teach you how to become more productive per hour. It's not, our goal is not to teach you how to answer the phone. Our goal is not to teach you how to, run a collection system. Those aren't our goals. You have a great program for that type stuff. But my goal is I want to teach you how to think differently about when you talk to a patient and when you schedule that patient, so that instead of being a dentist that's doing $375 or $400 an hour, we have a lot of our dentists that are doing $1,000, $1,200, $1,400 an hour. It changes your life because now you have options. You can continue to make more money. You're helping more people, by the way, which is very good. It's doing good while doing good. You're helping more people. You're getting to do more dentistry. And you've got choice. You could be like me. You could say, hey, I just want to work 2 days a week. Why? Because I've got 5 grandkids with 3 on the way, 5 daughters. I'm one of those, just the opposite of you, but I've got all these girls having babies now, so it's crazy. So I want to be able to spend time at home. I also like playing golf, so I want to have a life. Plus, I'm going to be 60 next year. I'd like to do stuff. I enjoy traveling. I enjoy doing all that, but I have the options now to work 2 days a week. I have the options to travel whenever I want to. And so those are the things that dentistry has the freedom to be able to do. And it's not about massive numbers of new patients. It's literally about taking care of the people that you see. Because if you can find ways to get them to say yes and find ways for them to do the dentistry, you'll have all the work you ever needed. We're not in competition.
And last but not least, you're a legend. You're a household name. I've never met any dentist that doesn't know you, but tell them why they should listen to your partner, a friend of yours, Wendy, who's got another podcast. They might be looking at this name, Wendy, a hygienist, and I know everybody's going to listen. I'm sorry. My personal trainer's name is Wendy, and I just got done swimming with her. Vicky. Why should they listen to Vicky's hour?
Well, Vicki was one of my coaches before I started Productive Dentist Academy. And so she just has an insight, not only as a hygienist, she also owns a few practices. And so she has a unique insight and an ability to be able to communicate in ways on the business side that I don't communicate that well. And so she when people get to hear her, they just want to hear more and more. So
I agree.
That's huge, and she has a very, very good insight from the team perspective, how it all fits. She works with all of our coaches, and it's a pleasure to watch her work, and a pleasure to be her partner too.
Well, hey, please look me up when you get to Phoenix. I'd love to see you. I'd love for you to come by the dental office and talk to my staff about comprehensive finance, compassionate finance. I'd love that. And seriously. I got out of high school in 1980 when you got out of dental school, and I've been following you, chasing you. You're a legend, and thank you so much for taking an hour out of your day to share with all of our viewers, and thank you for all that you do for dentistry.
Hey, thank you, Howard. I enjoyed.
All right, buddy. Bye-bye.
All right, bye.